working in a large transplant center, transplant and non-transplant anesthesiologists have the opportunity to care for patients with cirrhosis. And as such, we are frequently required to assess their hemostatic status and fix it if need be. Now, you wouldn't want your mechanic to fix your car without knowing what's wrong with it, and surely we shouldn't expect anything less from ourselves. With that in mind, today's topic is the hemostasis of cirrhosis, and it is intended to bridge some of the gap that we might have in the matter and help us to improve our management. We would do a quick update on the current understanding of the coagulation process. We discussed the limitation of the common coagulation tests like PT and PTT, and then delve to the specific hemostatic abnormalities that are found in cirrhosis, and we'll close with clinical points. We use models as a way to conceptualize and understand complex systems. A good model should be easy to understand, yet complex enough to accurately reflect the process it represents. And in 1964, English and American researchers proposed a model for the coagulation process due to its staggering complexity. According to the model, coagulation can be initiated via one of two pathways: intrinsic or plasmatic activators trigger the sequential activation of factor 12, 11, and 9. Factor 9 then binds factor 8 as a cofactor to form the intrinsic tenase. Alternatively, tissue factor upon exposure to the blood binds and activates factor 7, and together they form the extrinsic tenase. The two pathways then converge on the activation of factor 10, and coagulation then proceeds downstream when factor 10 binds factor 5 as a cofactor, forming the prothrombinase. Thrombin and fibrin are generated, and a clot is formed. This model definitely advanced our understanding of the coagulation process. It's a great success and is still taught till this very day. It is pretty straightforward and accurately reflects the orders of many of the in vitro found enzymatic reaction of coagulation. But does it reflect the in vivo process accurately? Well, the hemostatic phenotypes of individuals with factor deficiency have proven to be troublesome to the model. One would expect that all enzymatic reactions of a cascading pathway to be equally important. However, genetic deficiencies in the intrinsic pathway taught us otherwise. Deficiency of the plasmatic activator of factor 12 are of no clinical consequences. Deficiency of factor 11 leads to a variable hemorrhagic tendency. In contrast, individuals with factor 8 or 9 deficiency succumb to hemophilia. And the model does not offer any explanation for these phenotypic differences. Moreover, even if we accept that only the downstream portion of the intrinsic pathway is physiologically relevant, how does it get activated? Two more recent discoveries shed some plausible explanation for that. In 1977, it was found that the extrinsic pathway can activate factor 9, and in 1993, it was found that thrombin can activate factor 11. Okay, that can settle and explains how the intrinsic pathway get involved in coagulation, but there remain even a bigger question looming. Why do hemophiliac bleeds? After all, the tissue factor remain as the primary physiologic activator, and coagulation in hemophiliacs should proceed via the intact extrinsic and common pathway. So why do they bleed? And the new millennia brought some fresh ideas, and two researchers from North Carolina, Hoffman and Monroe, suggested that when triggered by tissue factor, the common pathway cannot proceed beyond thrombin. Rather, thrombin then must activate the intrinsic pathway, and only the intrinsic pathway can activate the common pathway at its entirety to lead to clotting. And they then suggested to rearrange the model from its Y-shaped order to one that is proceeding in tandem: extrinsic, then common pathway to thrombin, then intrinsic, and then the entire common pathway to clot formation. But what would steer the enzymatic reaction in the proposed sequence? Well, the model suggests that the coagulation process is a sum of enzymatic reaction. The model does recognize that negatively charged phospholipids are required for the proper assembly and function of coagulation complexes. And the role of cells, especially platelets, was understood as to provide these negatively charged surfaces. However, recent discoveries taught us that cells differ significantly in their coagulative properties. Cells are able to localize components of the coagulation process to their surface, And this localization serves to control the process, and what Monroe and Hoffman suggested also to steer the reaction in the proposed sequence. And in 2001, they proposed a new model that intertwined this newly found role of cells with the rearranged enzymatic reaction. They aptly named it the cell-based model and divided it into 3 phases. Upon injury, tissue factor on the subendothelial cells is exposed and initiates the extrinsic pathway. Factor 10 is activated. However, subendothelial bound factor 10 is very inefficient, and only minuscule amount of thrombin is generated, not enough to lead to fibrin or clotting. On the cellular side, von Willebrand factor attaches itself to the collagen on the exposed matrix. It then tethers platelets. We see here the formation of 2 membrane tether between the platelets and the von Willebrand factor on the carrying glass. And this tethering activates the platelet. They become sticky and they aggregate. And then thrombin diffuses to the platelets aggregate and fully activates them to release factor 5. And thrombin then activates factor 5. It also releases factor 8 from von Willebrand factor and activates factor 8. The activated 5 and 8 then remains attached to the surface of the platelets and then localize all subsequent reactions to the area. Platelets then set the stage for a large-scale production of thrombin and fibrin. This is because the platelets-bound prothrombinase and tenase are 1,000,000 times more active than unbound complexes. And coagulation then proceeds in a large scale through the intrinsic and the common pathway, and a clot is formed. Of course, the role of coagulation is not only to control hemorrhage, but also to ensure the patency of the vasculature. And this is achieved by a very careful balance of pro-hemostatic and anti-hemostatic drivers, which includes pro and anticoagulants and pro and anti-fibrinolytics. On the anticoagulants, we'll mention the antithrombin, the targets of heparin, and the protein C, protein S system. This diagram also shows us the central role of thrombin, not only as the direct activator of fibrinogen, but also as a controller of many pro and anticoagulants, pro and antifibrinolytics, and the activation of cells as mentioned earlier. With this introduction, at this juncture, we can start to discuss the topic. And cirrhosis is characterized by bleeding episodes and laboratory values suggestive of hypocoagulation, that is prolonged PT and low platelets. It is still featured as the epitome of acquired bleeding disorders, and it is believed that PT and platelets are indicative of the bleeding risk, and as such, for decades they were used to guide therapy, how to treat a bleeding episode, or in minimizing the risk of bleeding during invasive procedures. It is well known that the decrease in synthesis is a hallmark of cirrhosis, and the decrease of procoagulants is accompanied by similar or commensurate decrease of the anticoagulant. And the significance of this comparable decrease escaped attention of clinicians for many years. Now, the colloquial use of coagulopathy equates it with hypocoagulability, but in fact, the literal sense, coagulopathy means abnormal to either side. And let's stick with this broader meaning and ask ourselves, are cirrhotics coagulopathic? Starting with the hypocoagulable side, what evidence do we have that they are hypocoagulable? Bleeding episodes may be suggestive, but are not absolutely indicative of hypocoagulability. It can arise from abnormal anatomy, high pressures in the vessels, and so on. Prolonged PT and low platelets are indicative of hypocoagulation in many clinical settings, but it's hard to ascribe hypocoagulability to cirrhosis based on these values because they are poor predictors of the bleeding risk. Moreover, it's relatively easy to fix this value, but frequently we fail to alter the course of hemorrhage during a bleeding episode. And thirdly, TEG, probably the most comprehensive, readily available coagulation test, is frequently normal or hypercoagulable in cirrhotics, despite INR of 2 or 3 and platelets below 50,000 or so. In comparison to known hypocoagulable state like ITP or patients with factor deficiency, cirrhotics rarely bleed even when they have comparable degree of laboratory abnormality. Moreover, you would not be able to perform minimally invasive surgery like a breast surgery or hernia repair in patient with ITP or factor deficiency unless you correct the deficiency. Yet, up to 50% of transplant recipients are performed without any transfusion. what kind of hypercoagulability lets you perform such an invasive procedure, probably one of the most invasive, without transfusion? Looking to the other side of the abnormal, are cirrhotics hypercoagulable? Well, portal vein thrombosis occurs in 15% of cirrhotics. They have increased risk of deep vein thrombosis and PEs. On the arterial side, cirrhosis offers no protection whatsoever from arterial thrombosis like strokes or MIs. That is, these patients are not auto-anticoagulated. Evidence for microvascular thrombosis is found in 50% of autopsies from cirrhotics. And actually, coagulation activation is implicated in the progression of liver fibrosis to cirrhosis. Hep C, for example, progresses much slower to cirrhosis in patients with hemophilia. And lastly, anticoagulation treatment, when given to treat or to prevent portal vein thrombosis, is safe and effective, improves survival. It doesn't increase the severity or the occurrence of bleeding episodes. I think unbiased clinician would conclude that cirrhosis is definitely not hypocoagulable, might even be hypercoagulable. And it's puzzling why, for decades, no clinician spoke against the prevailing dogma that cirrhosis is a hypocoagulable state. And Hans Christian Andersen tells the story of two con artists, two tailors that fooled the king and queen to believe that they have these marvelous garments that are invisible to the stupids or those unfit to royalty. And as the king and queen marched proudly in their town, none of the town folks expressed their opinion about the appearance of the king and the queen, lest they would appear to be stupid. And it's only thanks to the naivety of a little boy that it was finally spoken out loud that the royal couple are naked. So it's really puzzling that in a world that evolves and changes so rapidly, clinicians hold to all dogmas that got engraved in the bedrock of our education early on as if they were sacred and above all and immune to any criticism. And that happened for decades, but eventually the dogma was challenged. How it transpired and who assumed the mantle of this little boy is as follows. It just so happened that the clinical and laboratory constellation of cirrhosis mimics that of DIC. There are the low platelets, low factors, some thrombosis, fibrinolysis. We find the D-dimers in the thousands in the operating room. And there is an ongoing controversy whether DIC plays a part in the pathophysiology of cirrhosis, or is it just happen to be a laboratory mimicry. And in 1999, an Israeli team decided to resolve this controversy once and for all, and they performed a very elaborate study and concluded that DIC is not part of the coagulopathy of cirrhosis. They were not able to resolve the controversy, but an editorial from St. Louis University, the author, rejects the result. He kind of rebuked them for their conclusion. He reasserts the role of intravascular coagulation in cirrhosis, and with a prescient statement, he attributes it to the hypercoagulable state of cirrhosis. To the best of my knowledge, this is the first reference to cirrhosis in our literature as a hypercoagulable state. But if so, why do the PT and PTT are indicative of hypocoagulability, not hyper? To understand that, we need to look very carefully, and this is a pivotal point in this presentation, the balance of pro and anticoagulants. Excess of procoagulants would lead to hypercoagulability. Decrease in anticoagulant opposing forces would also lead to hypercoagulability. A decrease in procoagulants would cause hypocoagulability, and a comparable decrease in anticoagulants would balance it, would even it out. In fact, if it's low enough, if anticoagulant drivers are low enough, the balance might tilt even towards hypercoagulability despite low levels of procoagulants. So to understand why PT and PTT fail to reflect the balance of coagulation in cirrhosis, we need to look at the protein C system. Thrombomodulin is a transmembrane protein expressed on endothelial cells. It binds thrombin and activates it, and together they activate protein C. Active C then binds protein S, and CNS complex then inactivates factor 8A and 8A, the two main cofactors of coagulation. Now, thrombomodulin speeds up protein C activation 20,000-fold, but it is a cell-bound, and the assays of PT and PTT plasma does not contain sufficient protein C, sufficient thrombomodulin for protein C to play any role. I thought to give an analogy here, if we look at control, healthy individuals, and they have balanced load on both sides of the pro and anticoagulant, and cirrhotics are also balanced, but with low level on both sides, then PT is supposed to be showing similar numbers. However, because of the lack of thrombomodulin, the assay is completely blind to the anticoagulants opposing forces and only reflects the procoagulants forces. And on the procoagulant forces, controls have twice or higher levels of procoagulant. So it reports you high, whatever is the control value of PT, and a very prolonged PT because it only sees the low level of the procoagulant in cirrhosis. It doesn't sense at all the anticoagulant that balance it. The second limitation of the study of the assays is a touch more nuanced. If we follow thrombin generation over time by measuring thrombin antithrombin complexes, we see that following an initiation period, thrombin generation commences, it accelerates and then decelerates and stops. The PT and PTT are clot-based assays, and clotting is sensed by sensing turbidity. And turbidity occurs early on, after only 3% of total thrombin is generated. That is, the assay is also unable to capture 97% of excess thrombin generation. They just conclude too early. And in summary, the assays are completely insensitive to anticoagulants, and they only reflect the procoagulant side. And they fail to capture excess from procoagulants. This is why there is no such thing as short PT. You never call hematologist a patient has a short PT. But the assays are indicative of low levels of procoagulants. And in fact, this inability of this assay to capture the hemostatic balance is not unique to cirrhosis. Let's look at another clinical scenario. A middle-aged woman gets admitted to the hospital with DVT. Coumadin is initiated, and as soon as it becomes therapeutic, she gets discharged home, only to return to the ER 4 or 5 days later with these lesions. This is skin necrosis due to thrombosis, and it is warfarin-induced skin necrosis. But how could a hypocoagulant do that? Coumadin is a vitamin K antagonist, and it blocks the synthesis of vitamin K dependent factor. We are aware of the 4 procoagulant 2, 7, 9, and 10. But in fact, protein CNS are also vitamin K dependent, and therapy with a vitamin K antagonist decreases levels of the anticoagulant as well. However, almost always the decrease in the procoagulant exceeds that of the anticoagulant, and the balance tips toward hypocoagulability. We care to see how much so we measure PT. But at times, protein C, protein S levels drop faster and lower than the anticoagulants, which leads to hypercoagulability, but the assay is unable to capture that. And the INR is 11 in these patients because the assay can only see the procoagulant level, and it's low. The same thing happened in liver, in cirrhotic patients. It doesn't see, totally blind to the opposing or lack of opposing factor of the anticoagulants. I do want to emphasize now, don't get confused. PT is an excellent marker of hepatic synthetic failure and hepatic failure in general. It's part of the MELT score. And it's also a prognostic indicator of survival in fulminant hepatic failure. We are only talking about PT as being able to, or unable to reflect the balance of pro and anticoagulants. So we have in our hands to affect hemostasis, we have platelets and FFP. And we want to learn how to use it correctly. We don't want to end up with a major bleeding, as you occasionally hear, but even more dangerous is the occurrence of major intracardiac clot and hemodynamic instability, or massive DVT, PE, or some other horrific complication of hypercoagulability in cirrhosis, such as portal vein thrombosis or hepatic artery thrombosis. Obviously, the hemostasis in cirrhosis is much more nuanced than previously appreciated and requires a more sophisticated assay, and such assay became available in 2003. When a thrombin generation assay was described, it came with a promise to reflect the interplay between pro and anticoagulants, and it is based on fluorogenic substrate and a fluorometer. And in 2005, a group from Milan decided to assess the enzymatic side of coagulation. That would try to give us some indication when does FFP is required, when is it required to treat, to be given to cirrhotics. So they used the assay to measure thrombin generation in cirrhotics. The patient population was typical in trends, prolonged PT, prolonged PTT, low levels of pro and anticoagulants, and elevated levels of factor VIII. In fact, these abnormalities are quite mild, suggestive that the severe cirrhosis was a small group in these 44 patients. They found that without thrombomodulin, when the plasma was as it is, controls have much more thrombin generation, expressed here on the Y scale as endogenous thrombin potential. It is basically the area under the curve of thrombin generation over time. And again, looking at the scale, we know that cirrhotics has lower level of both pro and anticoagulants, and if we don't put thrombomodulin, protein C is not activated and does not come into play. And thrombin generation is only a factor of the procoagulants, and controls would generate much more because they have much more procoagulant levels. But when thrombomodulin in a soluble form is added to the plasma, remember it is a cell bound, then of course it activates protein C, the anticoagulant opposing forces come into play and decrease thrombin generation in both groups, but more so in control, to the point that cirrhotics and control show similar amount of thrombin generation. And they concluded, the authors concluded, they found evidence for normal thrombin generation, and this is a groundbreaking laboratory evidence that cirrhosis is not a hypocoagulable state. This is the first proof for that, and the publication was met with significant skepticism, and an editorial from Barcelona University lashed at them, and the author states that the profound hypocoagulability of cirrhosis is firmly established. The undertone is like, we have a theory, don't confuse us with fact. The comments was, he did not put platelets, there was no standardization of the assay, and the cirrhotics were not sick enough, and so on. But the skepticism and the editorial were not enough to curb the enthusiasm of clinicians with the new paradigm, and clinicians started to look into the hypercoagulable results of cirrhosis. And a year later, a study from University of Virginia, reported that 0.5% of all admissions involving cirrhotics result in a new onset of venous thromboembolism. And a large population study in 2009 from Denmark calculated the adjusted risk to be double that of non-cirrhotics. And that motivated the Milano group to look more carefully into the balance between pro and anticoagulant. In that study, they looked into 3 groups: control cirrhotics and patient heterozygous for protein C deficiency. They looked at pro and anticoagulants. On the anticoagulants, protein C levels that were normal in control decreased progressively with the increase in the child Pew score, to the point that child C had lower levels of protein C than heterozygous protein C deficient individuals. On the procoagulant, we mentioned that factor VIII is known to be elevated in cirrhosis, and it increased progressively with worsening cirrhosis, and the balance between the pro and anticoagulants increased from 1 in normal individuals to 5. Then they looked at thrombin generation, but this time they expressed it not as the absolute thrombin generation, rather as how much administration or addition of thrombomodulin, and thus activation of the anticoagulant opposing forces, can inhibit thrombin generation. And in control, they found that when you unravel the effect or unmask the effect of the anticoagulant opposing forces, thrombin generation is decreased by 1/3. But in cirrhotics, it decreased only by 1/5. This resistance to the effect of thrombomodulin protein C, protein S is most likely due to the low levels of protein C and protein S in cirrhotics. This resistance increased progressively with worsening cirrhosis, and they this time concluded that they found evidence for hypercoagulability as opposed to the normal thrombin generation that they reported in 2005. And they attributed the increased risk of venous thromboembolism to this hypercoagulability. And a similar methodology study from the Netherlands in 2009 looked at the same idea in pre-transplant period. And the blue arrows indicate the controls, and at the get-go, at the beginning of a case, cirrhotics without thrombomodulin showed the typical excess thrombin generation. Decreased thrombin generation compared to control. But when thrombomodulin was added, thrombin generation in cirrhotics was almost twice as much of control. This is because control have higher level of anticoagulant forces. Equally important is the finding that this resistance to thrombomodulin protein C and excess thrombin generation in the recipients persisted 5 and 10 days post-transplant, still higher than control. That is, the hypercoagulability state of cirrhosis extend way beyond the first few days of transplant. So a plausible explanation, of course, is that the levels of protein C and S recover much slower in the post-transplant period. So the authors look into that. Horizontal bars shows the reference value, and we find that protein C, S, and antithrombin level recover to normal within 5 days and 10 days. So what could be the reason for this persistence of hypercoagulability? And they looked into factor VIII level. We said that factor VIII level in cirrhotics is elevated by the increase almost 10-fold in the post-transplant period. This is due to the fact that factor VIII is an acute phase reactant. So what we see from here is when it comes to the enzymatic side, when you consider to give FFP or cryo, don't ignore the factors level, ignore fibrinogen, ignore the PT. If the patient doesn't bleed, don't deal with this. All you can do is just cause trouble, because these patients are hypercoagulable enzymatically. But what about the cellular side? Do they need platelets? So we spoke about the dual role of platelets in cirrhosis, adhesion and aggregation and forming the initial platelets plug that seals the vessel, and orchestrating and contributing to thrombin generation. Starting with the adhesion and aggregation, the Milano group collected blood, separated the plasma from the cells, and resuspended the RBC and the platelets and adjusted the hematocrit to 40 and the platelet count to 200,000. Then they perfused the mixture over a collagen covered surface and measured how much of the surface is covered by microthrombi. And this what was found when control platelets were resuspended in control plasma. When cirrhotic platelets were added to control plasma, we see more or less similar area, more scattering, smaller or more numerous, but the area was more or less the same. However, when platelets from control or cirrhotics were resuspended in cirrhotic plasma, that's what was shown. It's extreme hyperaggregability of platelets of any type. If you give platelets from the blood bank or patient's own, you can cause this severe hyperaggregability in these patients. And this is not only in 200,000. The same result was found when the platelet count was adjusted to 100,000 or even 25,000. So at least when it comes to aggregability, you can ignore the platelets count. Don't fix it. If the patient does not bleed, don't even consider it. They attributed this hyperaggregability to the elevated level of von Willebrand factor. We know that von Willebrand factor is not synthesized in the liver, rather by other cell lineages, and its primary inactivator or pyrolytic enzyme, known as ADAMS13, its levels are known to be low in cirrhosis, thus leading to this excess hyperaggregability. Now, looking at the not at the other role of platelets in orchestrating and contributing to thrombin generation, the Milano group studied thrombin generation with and without thrombomodulin, the same methodology, but this time resuspended the platelets, added platelets to the plasma, and adjusted the platelets count to 100,000. And the result is very similar to what was found without platelets, that in the absence of opposing forces, controls have more thrombin generation than cirrhotics. But when you let both forces to come into play by the addition of thrombomodulin and activating protein C, the level of thrombin generation was similar in control and in cirrhotics. They went a step ahead and adjusted the platelet count to the individual's original platelet count. So of course, in controls, the average was 200,000, and in cirrhotics was 80,000. And now was a little bit decrease in thrombin generation, statistically significant, but a mild decrease in thrombin generation in cirrhotics. But that enabled them to plot thrombin generation versus platelet count. In closed circles are the cirrhotics, and they found out that thrombin generation increased with the increase in platelet count in both groups. They then estimated that a platelet count of around 60,000 in cirrhotics is sufficient to generate normal, low normal levels of thrombin compared to cirrhotics. But they do comment that the platelet count does play a little bit of a role. So if we integrate the role of platelets of the two studies, we can conclude that platelet count as low as 50 and even lower have normal or even hyper function, excess or platelets hyperactivity in cirrhosis. This tells you that we shouldn't transfuse platelets for no reason, just based on a platelet count. The other arm of hemostasis is fibrinolysis. Much less is known, and hardly any work was done in this area. We know that abnormal levels of pro and anticoagulant of fibrinolytics occur in cirrhosis. It is believed, just a belief, that the balance between pro and anticoagulants fibrinolytics is restored in cirrhosis. But we do know that some patients, about 5 to 10% of them, are at baseline hyperfibrinolytics. Some patients will tell you that they are told by their hematologist to swish and spit Amicar whenever they have gums bleeding and so on. Our division actually spearhead research in this area. We looked into the 3 phenotypes of fibrinolysis: normal, physiologic, hyper, and hypo. We found out that physiologic fibrinolysis occurs in 20% of our recipients. 8% of our recipients are hyperfibrinolytic, similar to the 5 to 10 number, but 72% of our recipients are hypofibrinolytic, a condition more commonly referred to as fibrinolytic shutdown. This is a common parameter in trauma anesthesia. So cirrhotics are not hypocoagulable, they are even hypercoagulable, but why do they bleed? Please. So GI bleed, the most significant bleeding observed in cirrhosis, is not due to hypocoagulability. It is due to increase in portal and splanchnic flow, increase in portal pressure due to the cirrhosis, some degree of endothelial dysfunction, and the portal hypertensive enteropathy, including gastropathy and colopathy. Mucosal hemorrhage or skin lesions, hematomas and bruises, are usually due to hyperfibrinolysis. And important to know that triggering factors such as infection, development of hepatorenal syndrome, or decompensation due to portal vein thrombosis leads to hemorrhage. It was actually found that if you give antibiotics, you control GI bleeding better than when you give factors prophylactically. So what is the take-home message here? First, forget about the old prevailing dogma. The current dogma in cirrhosis that it is a hypercoagulable state. And the balance that occur in cirrhosis, hyper or normal, is very unsteady because the scale has low weight on either side. Minimal perturbation will tilt it from hypo to hyper and from hyper to hypo. In fact, in transplant anesthesia, the Achilles heel of these cases nowadays is not hemorrhage. As we said, up to 50, some centers even say 70% of the patients require no transfusion. What we deal with today are catastrophic 3 to 5% of cases that develop intraoperative clots, and people, especially the cardiac team knows, we call them frequently to help during this catastrophe with TE and so on. And we in this center and in other centers, almost 50% of the centers give nowadays heparin during liver transplant, give heparin to liver transplant. The balance varies between individual. You cannot assume that every individual is hypercoagulable, hypocoagulable, and so on. As we said, ignore the lab numbers. Don't correct abnormal lab numbers. Start to consider correcting things only if clinically indicated, that is, the patient is bleeding. Don't cancel cases because the platelets are low or the PT is prolonged. We got cases in which the anesthesiologist thought that the patient cannot withstand dental extraction or go to GI for biopsy or so on because they are cirrhotics with abnormal labs. That's not correct. These patients would withstand invasive procedure. They would withstand liver transplant. And if you do want to know the balance of your patient or to know what to expect if the patient bleeds and so on, probably the best test that is readily available to us is the viscoelastic test of TEG or ROTEM if you're in trauma. It was shown that transfusion of factors to prepare patients for procedure or during a hemorrhagic episode can worsen the hemorrhage. And this is attributed to the hypervolemia that some of us cause when we transfuse without considering the amount of the volume. And that by increasing the venous flow and the splanchnic flow and the portal pressure, you worsen the bleeding. Of course, we need always to look for precipitating factor. We are very, very careful not to take patients with infection to the operating room, not only because they're going to be immunosuppressed, but because we know they're going to display significant perturbation, hemostatic perturbation during the case. Now, as anesthesiologists, we notice causality to our action when there is a temporal or spatial proximity of an outcome to our action. You give propofol, there's hypotension, and so on. However, that doesn't mean that the impact of our actions or decision do not carry farther beyond the operating room, days and maybe months or years. In PD anesthesia, we know that the choice of anesthetics can affect the child cognitive functions years later. Outcome research shows that hypotension in the OR can cause MI days later. But our study of hypofibrinolysis or the fibrinolytic shutdown in transplant showed or revealed that hypofibrinolysis is associated with catastrophic hemorrhagic and thrombotic complications, both intra-op and post-operative. Incidence of DVT, PE, and portal vein thrombosis occurs exclusively in patients with fibrinolytic shutdown. Moreover, the two abnormal phenotypes, hypo and hyperfibrinolysis, are associated with poorer outcome after the procedure, less survival. So it's very important that when you care for a cirrhotic in the operating room and you feel good that you finished the case successfully, the patient will breathe, but also remember, did you doom the patient to or expose the patient to a major outcome problems by rendering the patient even more hypercoagulable, more abnormal fibrinolysis phenotype, and so on. So you need to be very cognizant of the hypercoagulability, the precarious unsteady balance, and consider each and every decision. And I probably would summarize it by saying, if it ain't broken, don't fix it. If you don't know what's broken, or you don't know how to fix it, just ask, consult a TG, consult a colleague. And hopefully with this, we'll be able to have a better outcome and better management of this patient. This is
We're going to open it for questions. I have a question. So pre-op, the PT is going to be, you use it as a prognostic indicator. But after that, do you use them at all? Do you use standard coags for any reason, or do you just follow TEG?
We follow TEG. During the case, we do follow PT and fibrinogen. We don't guide the therapy based on the PT, but mainly based on the fibrinogen level and mainly the TEG.
So why get the PT at all if it, well, once you establish the patient is at high risk, and why would you follow PT later on?
Because
we're not going to do anything about it.
Because the MELD score play a prognostic role, but it's not necessarily due to the hemostatic balance, but rather as a sign of the severity of the liver failure. We know that it affects survival as an indicator of the synthetic failure. Synthetic failure.
But if you already established that pre-op, you already established
the score. If two cirrhotics have decreased level, but one is this low and one is this low, and this is the normal, the one with low levels would be even more inclined to have perturbation. You have less weight. So PT and hepatic, the synthetic failure does play an indicator in survival, and it can tell you sometimes to be, that this patient is really severely cirrhotic and very, prone to perturbation, but mainly because MELD score was shown to have some survival prognostic indication.
If you say that 70% of the patients have a fibrinolytic shutdown who are cirrhotic,
yes.
So that means that TXA would be contraindicated in all of these patients?
That's an excellent question. We in the liver transplant would initiate Amicar or tranexamic acid, unlike trauma, only if there is a fibrinolysis or DIC, whether it's primary or secondary fibrinolysis, and only after we blocked the coagulation by giving pretreatment with heparin. Only then. Only then. 10 days ago, there was a case, and the heparin was given, and we give it routinely, and then the heparin effect, the protective heparin effect was reversed with protamine because the patient was bleeding, and the patient immediately showed massive bleeding and developed intracardiac clot because the patient behaved as having this imbalance with activation, DIC-like picture. So yes, we never give Amicar unless we have pretreatment with heparin. We verify it by looking at the ratio of the with kaolin heparinase and without, and once it's therapeutic, then we would initiate Amicar if indicated.
Got it. Any other questions? Yes. Hold on, Mike. Just pass this.
Rava, it's a great talk. I think it's an example that not all bleeding is the same. DIC patients, liver patients, these are patients, when we start using factor concentrates like PCCs and factor 7s and all these other exotic things that we need to think differently about. But my question for you is, what do you think modern bleeding management looks like? I mean, is TEG enough? Should we have algorithms? Should we be using platelet analysis? I mean, what should it look like?
Excellent. We actually published this year a manuscript in which we propose an algorithm. I don't know if it's the first of, but an algorithm that integrates the principles of this presentation and is tailored to protect us from the development of hypercoagulability and clot. And there are things that are unique to transplant, which I did not talk about, that during a transplant case, there is an accumulation of triggering factors for DIC. This is, nowadays, some of you know, we collect ascites and we mix it with patient blood and volunteer blood. This is a study that is ongoing right now. And the first 3 patients showed us severe hypercoagulability of plasma, of ascites. We know that ascites contains some collagen, and as you saw, it can bond with Willebrand factor, initiates platelet aggregation, and so on. And it's amazing result, and we think that as the raw surface during multivisceral on liver transplant is bigger and bigger, some of the ascites get absorbed and start to trigger the havoc. Other mechanisms are the accumulation of tissue plasminogen activator and the inability of the failing liver to clear the circulation. This is part of it's not only synthetic failure, but also clearance failure of the liver. And as we go into the hepatic stage, we see even more so, worsening hypercoagulability. And so our protocol is tailored very much to address those changing coagulopathy during or coagulation balance during the case. And early on, we give heparin, and if there is indicated, we treat hyperfibrinolysis with antifibrinolytics, but only after protecting it with heparin. So we do have, I'll be more than happy to send you the manuscript and you would see for yourself. We presented that in different forums, and it was, accepted, favorably by our colleagues.
Ramona, do you have a comment?
So there is also a change in etiology of liver disease. So from viral hepatitis, now the #1 indication for liver transplant is going to become soon NASH. So obesity itself, it's a pro-inflammatory and chronic inflammatory state, which is messing up with coagulation and this imbalance. So we are going to see more and more portal vein thrombosis as in the pre-op, and more patient with hypercoagulable state. Regarding the fibrinolytic shutdown, which we found in 70% of our patient population, it's impressive how those patients during the surgery, they changed this to fibrinolytic states documented by a TEG in 30% of the cases. So the fibrinolytic shutdown is changing to a fibrinolytic state, or even the IC state. So once you trigger the surgery, you never know how these patients are going to change the coagulation status. So the protocol which Dr. Rave mentioned, giving the heparin and Amicar, it's very, we are trying to implement it, so we have a lot of resistance in the transplant world that giving heparin before Amicar, so everybody in transplant world is not giving freely Amicar. So, but we are trying to prove why it's safe and why we are not going to increase the bleeding by giving heparin and so on. So still a lot of things to research. Thank you.
Any other questions? If not, we're going to wrap it up, and we're going to thank Dr. Rabe for a very nice presentation.
Thank you.